Is Ms. Campbell there?
Yes, I am, John.
Dr. Klein, I'm here too, but where I am, it's afternoon.
Oh,
Sure, I'm here.
Okay, why
This
do,
is Lynn. I'm here too.
okay. I think that, well, it's 4 o'clock. Why don't I call the meeting to order? For those that are joining us by telephone, could I please remind you to mute your, we don't pick up the background noise. And then also, please do not put us on mute. Don, do you have any other announcements other than those two?
yeah, so please put us on mute, but do not put us on hold. The holding puts us a lot of background music. So if you do need to step away or take another call, please hang up and then redial.
Okay. Do you want to go ahead and take roll call, John, and make sure that we have a quorum?
Sure. Ms. Johnstone? Ms. Lewis? Dr. Klein?
Here.
Ms. Kerr?
Here.
Dr. Ford? Director Wilden?
Amber Joyner as his designee.
Commissioner Kipper?
Here.
Director Mollenkamp? Vice Chair Atkins?
Here.
And Chair Campbell?
Here.
We have a quorum.
All right, thank you.
Levon Lewis.
Ms. Lewis, thank you.
Yes.
Has Ms. Johnstone joined the... Okay, I'm sure that she'll let us know if she joins, but we have a quorum. All right, with that, I'm going to open it up for public comment. If anyone would like to participate, please identify yourself for the record. All right, hearing none, we'll move on to agenda item number 3. And John, this is your update on the legislative bills that may have an impact on the health insurance exchange.
That's correct. For the record, John Hager. So you'll see on page 1, Senate Bill 352, Senate Bill 359, and Assembly Bill 251 did not make it through the appropriate committee or House, and therefore those 3 bills are dead. Senate Bill 359, I don't know if you may have seen it, we've noticed a workshop for regulation that took the language from Senate Bill 359 and would put that language in our regulation. That was in response to a potential to amend Senate Bill 454 to include it, and trying to get it through the legislative process. We were concerned about having an amendment in Senate Bill 454 at this late hour, and so we noticed the workshop for that does that, and that's section 2 of the proposed regulation that will be heard on June 12th, and then the final adoption hearing would occur on July, I think it's July 10th, whatever the second Thursday, maybe it's July 11th, the second Thursday of July.
And John, just so that the members know, that the regulation is an exact duplicate of what was in, let's see, was it 352?
359.
359, and that language has been approved by the board at earlier meetings.
Correct. Additionally, 2 other bills have passed through the legislature. Assembly Bill 65 has been approved by the governor, which revises various provisions relating to open meetings, and then Senate Bill 318, which is on its way to the governor's office, and that was an interim study from the Committee on Health Care. So that skips us through pages 2 and 3. On to page 4, Assembly Bill 425 is the Division of Insurance Omnibus Bill that allows the DOI to certify navigators, enrollment assisters, and certified application counselors, align state law with the Affordable Care Act, and allows the Division of Insurance to do network adequacy. That bill I believe, is going to the House floor this evening. I'm not positive of that. Commissioner Kipper, do you have any update on that bill? You stepped away. So I think that's the case. I think it has gone through the committees in the House, should go to the floor, and then it should go to Senate committees over the next several days. Assembly Bill 489 is still sitting there. It's been declared exempt, but it has not had any hearings since its original hearing. So it doesn't appear that one's moving forward, but it's still alive, so who knows. Assembly Bill 266 has passed both houses, but it's passed in different versions. The third version that was passed by the Assembly, it makes the bill effective for all plans on January 1st of 2015. We don't know which version it will end up being approved. It's got to go back to the Senate for concurrence. This is the one regarding orally administered chemotherapy. Skipping on to, I guess the last one is Senate Bill 454. We had a hearing this afternoon. In fact, we just got back from that before the Assembly, Commerce, and Labor. A lot of tough questions there. It appears that I don't know if it'll go forward or not. I think it will go forward, but it appears that it will be amended. I don't know exactly what will happen with it. I spoke with the chair of Assembly Commerce and the chair of Assembly Ways and Means afterwards, and they both appear to be committed to moving it through, but I don't know in what form or what version that will take. With that, I'll be happy to take any questions.
Do we have any questions from board members to Mr. Hager? Okay. John, on SB 454, will that go to workshop?
It is supposed to go to a workshop, work session on Friday. Is the Assembly, Commerce, and Labor's next meeting. So on Friday, we should expect it to go to workshop. And any amendments that they would propose would occur at that point. And then after that, it would need to go to Assembly Ways and Means. It would go then to the floor of the Assembly, and if there is an amendment, it would have to go back to the Senate floor for concurrence. And all of that, I believe, by midnight on Monday, or whatever time they designate as midnight on Monday.
Okay. Do any other members have any other questions? All right, John, thank you very much for that report. Let's move on to agenda item number 4, which is reconsideration or possible reconsideration of recommendation number 5 from the Plan Certification and Management Advisory Committee.
And for the record, John Hager, in September 2012, the board approved Plan Certification Committee's recommendation number 5, which limited the number of QHPs offered by each licensed carrier and each metal tier in each market, the individual and shop, to no more than 5 plans. Staff has interpreted this to limit to be per service area, so no single individual will have access to plans, because no single individual will have access to plans outside the service area in which that person lives. It didn't make complete sense. We forgot to include the service area requirement, but it did make complete sense to say 5 per tier per market when if a carrier offers plans in all 4 markets or in all 4 service areas, they might be able to offer 2 in one service area but 1 in the other 3, whereas a carrier that offers in just one market would be able to offer 5. So it really made more sense to do it per service area. During the May 15, 2013 Plan Certification Advisory Committee meeting, there was a request by a committee member to increase the number of qualified health plans that could be offered by each licensed carrier. This request grew from the discussion to allow plans to offer dental coverage embedded in a QHP or bundled with a QHP. The argument was that if a carrier offers a plan with dental coverage, they should be afforded the opportunity to offer an equal plan without dental coverage. There's one additional discussion that was not included in here that we forgot to include yesterday, that I forgot to include yesterday, and that was regarding the Medicaid MCO transition QHP, and the fact that we are requiring carriers, basically two carriers, to each offer one MCO transition QHP in a service area. And so, staff's recommendation is that the exchange allow each licensed carrier to offer 5 qualified health plans per metal tier, per market, shop and individual, per service area, and that one silver Medicare MCO transition QHP required to be offered in the individual market in each service area pursuant to the MCO contract with Medicaid will not count against the 5 qualified health plans. With that, I'll be happy to take any questions.
All right, I'll open it up for discussion with Mr. Hager for questions. Do any of the members have any questions? Or Dr. Klein, do you want to add anything to this agenda item as you're sharing the responsibility of that committee with me?
Thank you, Ron Klein. Yeah, what I thought you were going to say, John, was that the dental plans weren't going to count against the 5, the total number of 5. What I heard you say was something about Medicaid, but I didn't hear you exclude the dental plans or change the number, so maybe I missed something. If you could clarify that again for me, please.
Yes, for the record, John Hager. So I didn't mention the dental plans, and I should say that the motion that I provided clarifies the service area and the Medicaid MCO transition QHP issue. I'm not sure which direction we should go for the dental, and I leave that to the board to decide. The discussion was, it started off around the bundled idea that you could offer you could offer a medical QHP without dental, and then you could offer a medical QHP with dental. That medical QHP could be the same plan, but whether or not it's bundled or not bundled would potentially count against your 5. So the question is whether or not, if it is bundled, whether or not you want to allow carriers to offer an additional plan, and it may make more sense to simply say that you can offer one QHP or one medical QHP, and then how you offer it with bundling or not bundling, I'm not sure exactly. The other side of that is for an embedded dental product. If you offer a QHP without it, you could also offer a QHP with dental embedded, but really that becomes 2 separate plans because you can't create, it would be difficult to create a medical QHP that is the same as another one with dental embedded. So it really becomes a little bit difficult to create one single plan. The other concern is that if we're changing the rules right now with basically a week and a half to go before those plans are due, whether or not that creates an unfair advantage to one carrier or another, I'm not sure. So with that,
John, let me jump in. I try to follow you. Let me tell the board members, other than Barbara, who put through this with me, is we spent 4, 5, 6 hours discussing dental plans, and at the end of the day, the best way to do this is to give people the opportunity to either include them or not include them. So what I'd like to do is to see us. I don't know if we can phrase this. Is basically the sense of the board was that no more than 5 per tier per service area per company, and keep that plan, or keep that sense of the board, if you will, and maybe just simply say something like, if a plan offers the same QHP with and without dental, that will only count as 1, however we can phrase that. I think that to me is what makes the most sense. Second, John, I don't understand, you're talking about Medicaid MCOs, which I presume means managed care organizations, but I have no idea what you're talking about and why this is coming up here.
For the record, John Hager, so Medicaid has a contract with 2 carriers to offer managed care a managed care organization. It's basically an HMO for for Medicaid, and so I think what happens, if I understand it right, is the managed care organization assumes the risk for the plans that are offered, and in return they manage the care of the individuals and hopefully lower the cost overall. That's the idea behind the contract. Early on, there was a discussion about how we were going to deal with churn, how we're going to deal with people that moved from the exchange to Medicaid and vice versa, and other forms of churn. And so what we have with the MCO transition QHP is a requirement of the Medicaid contract that it requires the winning vendors for the MCO contract to provide a commercial product on the exchange that has certain characteristics that ease the transition of an individual going from the MCO to the commercial side or vice versa. So the idea is that if a person has been on Medicaid in the last 6 months or 12 months, or is coming from Medicaid, and we would include this MCO transition QHP, this commercial product, at the top of the list for that group of people only. So basically, it's during a special enrollment event. They're moving from Medicaid to the commercial market, and if that person signs a HIPAA release, then we would send a flag to the commercial product, and they would that would allow them to get the health data from the MCO side of the business to the commercial side of the business. That would allow them to manage the episode of care or chronic condition without creating a lot of additional hassle for the individual moving from Medicaid to the commercial product. So that's the idea behind it, and it was that was our strategy for the past year going forward to mitigate the effects of churn. We are doing what we can to mitigate the magnitude of churn through the enrollment process, but that is what the solution was. And because of that requirement, and I apologize for springing it on the board without having written it up, but because of that requirement, we feel it's appropriate to allow those two organizations that have that requirement to not have that plan count against their 5 plans.
Okay. I understand.
And it's one single silver plan in the 2 service areas that have MCO contracts, one in Clark County and one in Reno, in Washoe County, and those. So you're only talking about 2 additional plans, one for each MCO organization in those 2 service areas.
Great. Just so we can move this forward, not that I don't want to monopolize this, but a motion along the lines of what I said before, John, in the sense of counting a single QHP with and without dental as a single plan as opposed to 2. Would that be a viable kind of way of counting things, or is there some problem with that?
For the record, John Hager, I think it could be viable for the plans that might be bundled. I'm not sure if it would work on the embedded side. When you have a qualified health plan that doesn't have dental embedded, and then you have a qualified health plan that has dental embedded, I think to meet the metal tier requirements, when you add that additional benefit, I think it affects it might affect the medical benefit side. I'm not sure if it makes sense or not. On the bundled side, you're talking about a qualified health plan, and that plan in and of itself is one of the QHPs, and then whether or not you bundle it or not, we'd have to. You could say that it could be offered both bundled and unbundled, but again, the problem with that then is that you are creating a scenario where the carrier has an additional option, an additional product that they can provide, whereas other groups that have decided to not offer dental or to have dental embedded would only get the 5. I don't know if that creates an unlevel playing field, and again, it could create problems this late in the game. I think I don't know if Commissioner Kipper has anything to add on that.
No, John, I think you've covered it pretty well. I think but it is getting late in the game as we anticipate filings start coming in here with a deadline of June 7th. Time is short to be making these kind of changes.
My only concern, I want to do whatever works, and I appreciate the time limitation, is the original intent of the board was that we not have individual carriers, offer 20 plans per tier to create, sort of to overload the system and try to get a marketing advantage, and that was a fairly long discussion we had on that subject. So I just want to make sure that while we try to accommodate these various permutations of dental plans, we don't throw that out and wind up with a carrier who's not offering dental plans at all or offering them all in one way, but using some loophole to now offer 30 plans in a tier. That's my only concern that I want to avoid.
And for the record, John Hager, so I think that we would avoid that scenario if we leave it the way it is. Again, I do think it's necessary to make sure that we're clear that it's per service area. And I do think it's appropriate for the MCO transition plan to not have that requirement counted against their 5.
Restate what your recommendation was again, if you would, now that I think I understand it all.
That the exchange allow each licensed carrier to offer 5 qualified health plans per metal tier, per market, per service area, and that 1 silver MCO transition QHP required to be offered in the individual market pursuant to the MCO contract with Medicaid will not count against the 5 QHPs in each service area.
That recommendation doesn't address dental, so that's where I'm losing you there.
And this is Lynn. May I ask just a quick question? So does that effectively mean 6, John, or it's only 6 if they're offering that particular product you're talking about?
For the record, John Hager, so it would only be 6 for for those 2 carriers that offer the MCO transition QHP. It would only be 6 for the silver level plan only in the individual market. So basically, in the individual market, you're going to have 5 per tier. So bronze, silver, gold, platinum, plus catastrophic. You can have up to 25 plans, but it's really only 5 per tier. A managed care organization could offer 1 additional plan in Clark County in the silver level, and 1 additional plan in the silver level in Washoe, and that's it. So it's not really.
So 7? I'm sorry. I'm feeling a little confused. So
it's so per service area. So we have 4 service areas, and keep in mind that if you are if you live in Clark County, you will only see the plans that are available to you in Clark County. You will not see the plans that are available to anybody else in the state. So the current direction is that we will offer, each licensed carrier will offer 5 plans per metal tier per market. Because of the service areas, staff has interpreted it and has promulgated to the carriers that it's per service area. We think that's appropriate again because if you had a carrier that's statewide and offered one plan in 3 of the service areas and say 2 plans in Clark County, that would be their 5 per metal tier for, let's say, the silver plan and the individual exchange. Whereas a carrier that offered only in Clark County could offer all 5 plans in Clark County. So we said 5 plans per metal tier, per market, per service area. This additional exception would be only for 1 silver MCO transition QHP in the service areas in which the MCOs are offered.
So, John, I think
total.
I think part of the confusion here, if I can, I'm sorry for talking so much, is that you're mixing 2 different things, and I think you're getting people confused. The MCO idea I understand and I agree with. So that's step 1, allowing, at least in Southern Nevada, Amerigroup and HPN to have additional. I understand that, and I'm okay with that. What I'm failing to understand is how what you've just said addresses the number of dental plans, giving carriers an increased number of abilities to offer plans because of the permutations of dental plans. I'm missing how what your recommendation is, how it addresses that.
For the record, John Hager, it does not add dental plans. I think there could be a number of permutations of how dental plans are offered, and we think that should be left up to the carrier. We are not sure that we should allow a carrier to offer additional plans beyond the 5. Forget the MCO transition QHP, but if you're offering dental plans with your qualified health plan, whether it's embedded or bundled, we're not. I'm not sure how increasing the number of qualified health plans would help things at this point. I do think that we should take another look at this for 2015, give a good thorough look at whether or not this makes sense, especially once we've got the web portal up and everybody can see how it runs. But I think at this point, I'm not sure it makes sense necessarily to add an additional qualified health plan. Or add additional qualified health plans because you've decided to offer plans with dental and plans without dental at this point.
My question, so maybe I'm misunderstanding. If you offer a QHP and one has no dental, one has embedded dental, and one has bundled dental, so 3 versions of the same medical plan, does that count as 3 or does that count as 1?
That would currently count as 3.
So isn't that the whole reason we're talking about this? Because we're trying to increase that number of 5 so that it counts as 1 rather than 3. That's what I thought the recommendation was all about.
That was my understanding too, Dr. Klein. It sounds like staff has is making a different recommendation at this point. Who is our AG that's on the line?
I'm not sure the AG's on the line.
The problem here, John, is that you're actually making it harder. They're making it harder for the insurance companies because if they can offer 5 plans per tier, then they have 5 plans that they wanted to offer. But now you've cut them down by half because they offer one medical plan with dental and one without. It counts as 2 rather than counting as 1. So my recommendation was going to be, again, the MCO thing is fine, and that's a whole separate thing. But my recommendation would be something along the lines of that a qualified health plan that offers the same medical plan with and without dental, even those 2 separate plans or 3 separate plans, depending whether it's embedded, bundled, or not offering, be counted as 1 rather than 3. That's what I'd like to say, if you can get me to that point.
And I have another concern. This MCO issue, I don't think has been properly addressed on the agenda or the description of what we're supposed to be talking about today.
This is Lynn. I agree.
Okay.
I know it's a big issue, John. I just want to make sure that properly giving the board enough information to make a decision and making sure that the general public understands what we're talking about today.
Sure, and go ahead.
This is Lynn. So getting back to the dental at the moment. So I agree with everything Dr. Klein is saying, but I'm also hearing both from staff and the Division of Insurance that it seems late to potentially change some of the rules. And I guess the difference is if it's I use the word rider, which is probably not the right word, but if it's going to be like Plan A for Anthem Blue Cross Blue Shield without dental and with dental, that potentially would be one plan. But you're saying that some of the plans don't have it they have it bundled they have it embedded rather than bundled. And so if it's bundled, it would say Plan A plus dental or Plan A without dental.
For the record, John Hager, that's correct, except I'm not sure that Plan A without dental would be exactly the same as Plan A with dental.
Okay.
By adding that dental product embedded, you affect the rest of the plan as far as premium goes, as far as the cost sharing requirements that are included in an embedded dental product could create a situation in which you need to change the cost sharing requirements in the medical plan so that it meets the very narrow metal actuarial values.
Mr. Kipper on the line.
Yeah, I was just going to weigh in here and say,
Give us your expertise.
well, I was just going to say, to address all of this, do we need to have a cap, or can you just have an unlimited number of plans which would address the question of embedded, standalone, affiliated dental plans?
The commissioner, I'm not sure if you were present. We had a long meeting, maybe it was 6 months ago or so, where we talked about this extensively. And the concern was that an insurance company can sort of flood a tier and try to gain a marketing advantage by putting 30 different plans in a tier with minor permutations of each, and thereby sort of seeing their product there, overwhelming everybody on the portal. And so that's the reason that the board initially said 5 per plan. And so I think the sense of the board was to keep that number. We just have to figure out how to achieve that without counting the fact that there are permutations of dental plans identified with the same medical QHP.
Is one of our attorney generals on the phone now?
Dennis Belcourt. Yes, I'm here.
Mr. Belcourt, do you have the agenda for today's meeting in front of you?
I am pulling it up right now.
So we're on agenda item number 4, which is discussion and possible action regarding reconsideration of Plan Certification and Management Advisory Committee Recommendation 5, approved by the board in September 2012, in which the exchange limited the number of qualified health plans that could be offered by each licensed carrier in each metal tier in each market to no more than 5. Ms. Campbell, you had a concern?
Well, the reason that we brought this forward to the board for reconsideration, Mr. Belcourt, is after discussion of dental coverage. The second paragraph under agenda item number 4 describes why we're bringing this forward. Mr. Hager has brought another concern before the board dealing with MCO on the churn issue for those providers that in Clark County and Washoe County offer this MCO coverage when patients come out or clients come out of Medicare or Medicaid and go into the commercial market.
Mm-hmm.
And I'm not sure that portion of the discussion has been properly noticed.
Okay, let me read. I'm reading over it's agenda item 4 on today's.
Well, this, Dr. Klein, I agree with Chair Campbell. I have in previous meetings expressed many concerns about churn, and I don't know if Mr. Hager intended to or didn't intend to talk about something, but he said that somehow these MCO plans have some kind of special designation or special exceptions or something. Maybe that was an unintentional statement, or maybe I didn't hear it correctly. But I think having a discussion about churn and people moving back and forth between managed care, Medicaid programs, and private programs that have quote unquote similar characteristics, which I think is a term that Mr. Hager used, I think probably bears a little further discussion.
Hi, how are you?
So, for the record, John Hager, so it wasn't my intent to have a long discussion about MCO plans and churn.
Yes,
the intent. Could you please put your phone on mute?
Hi, what's going on?
Can you please put your phone on mute? It wasn't our intention to have a discussion about Medicaid MCO transition plans, but rather to increase the number of qualified health plans offered through the exchange by 1, by basically not have that transition plan count against the number of qualified health plans pursuant to the agenda. So I apologize for not getting it in the report last night.
Yeah, okay. We have someone joining the phone call that's on another phone call and talking in the background. Could you please mute your phone?
have no problems with adding a number to and not having it count against them. I'm fine with that. But I do think I do think if there are any kind of special exemptions or things that we're doing different for these MCO plans in terms of the transition, anything different than any other than any other policy, I think that merits further discussion. So again, I may be reading too much into what you said, John, but that's what I thought I heard you say, that there were going to be some differences in these as opposed to every other plan.
I will bring that back to the June meeting. I'll bring back the discussion of, so setting aside the not counting the one silver MCO transition plan against the carrier, I'll bring back everything else to the June board meeting for the discussion about, probably June, to discuss the our intention for the Medicaid transition plans and how that would work.
And this is Lynn, Madam Chair. So in principle, and I guess after the discussion that we did have quite a long time ago, I have no interest in expanding the number of plans in general. So if there is a need and a way to do as Dr. Klein suggested, which is kind of, if you have the exact same plan plus dental, that would not count against you, I'm fine with that. But otherwise, the idea that this is potentially opening up kind of the floodgates to a lot more plans, which I think will harm the consumer and make a choice of which plan much more difficult, I would oppose that.
Ms. Atkins, I think the discussion that took place at the advisory committee was that if a carrier decided to offer an embedded or bundled dental plan, they could now have 6 plans instead of 5. And I guess then, in my mind's eye, the most that they could ever have would be 10, because if they were 10 QHPs and then they wanted to offer 5 more with dental that duplicated the QHP except having a dental element in it, I don't see it getting any larger than that, but in the discussion I didn't see that many carriers that would want to do more than 1 or 2 dental programs.
This is Ron Klein. So my concern, and maybe I'm getting paranoid in my old age, is that a carrier, rather than offering 5 plans and 5, with and without dental, as we're assuming they would do, chooses to use that option of 10 plans and instead offers 10 with 1 dental variation as opposed to 2, and then simply has 10 more, and then simply has twice as many plans to offer. That's sort of my concern, is that somehow we want to increase the number, but we want to be specific and say this is not a way of opening the floodgates and allowing you to have 10 plans all with the same dental. But the number only increases if you have variations of the dental service, not basically doubling the number and saying, yeah, you can have 10 plans even if you're offering all of them with the same dental program.
Yeah, this is Lynn. I would agree with that, and I think Mr. Hager was saying that if they are embedded, they won't necessarily be the exact same plan plus dental as if it were a bundled. So a bundled might be a plan plus a dental, a plan plus or minus a dental, a plan plus or minus a dental. But when you start getting in embedded, that starts getting a little bit trickier and a little bit more confusing. So. John, I know you didn't use the word confusing, but that might not be exactly a plan plus a dental.
Correct. So I think we're actually potentially talking about 2 separate things. What I heard Dr. Klein say was that let's just break it down to a universe of 1 plan or 2 plans. You have medical QHPs A and B. And that I thought what he was saying is that you could offer it with multiple dental plans. So there's 2 different variations. One is you say plans A and B can both have a specific dental plan and can both not have dental. And I think what I heard Dr. Klein say, maybe I was incorrect, is that plans A and B could be offered without dental or with varying dental plans. I'm not sure
I'm agreeing with what you're saying. So let me say it again. Maybe I'll try to say it more clearly. Basically, the number 5 should be relevant to the medical QHPs. So if you want to offer, there's medical plan A, B, C, D, E, and there's A version 1 with no dental, A version 2 with embedded dental, and A version 3 with bundled dental. And as far as I'm concerned, that's one plan. That's A. But theoretically, if you did that for A, B, C, D, E, with all 3 permutations of dental, that would be 15 different plans. So what I'm trying to say is I'd like us to phrase this in some accurate way so that the 5-plan limitation refers specifically to the medical QHP and is not affected by the various permutations of the dental plans.
But Dr. Klein, this is Lynn. Are you suggesting, though, that there might be 5 different dental plans attached to each QHP?
I think, and again, this was a very painful discussion, a very confusing discussion. I think there are just various ways you can have, I'm assuming, again, maybe I'm wrong, a single dental plan, but there are 3 different ways you can have it. You can embed it in the plan. You can bundle it with a plan, which I think is slightly different. And you can not offer it if I'm right. So what I'm saying is those 3. I'm assuming one dental plan offered in 3 different legal ways. Please somebody correct me if I'm wrong.
But I guess my question is there only one dental plan, or are there 5 different kinds of dental plans they could attach to each of these? I guess that's what I'm saying.
I think there's one dental plan. Is that correct, John?
Let me ask, do any of you want public comment from any of the carriers or the dental providers?
Sounds like a great idea.
Is that all right to the board?
Sure.
Okay.
Sure.
Do we have anyone on the line that might offer some clarification to our questions? Or
This is Leanne Gassaway with AHIP. If I could offer a few things that might help kind of work. I think what I've heard is consistent with, I think we're all saying the same thing, or what I'm hearing is all the same thing. I think it's just being said in different ways. And I think we all have to recognize that the way that these products now are being filed with the Division of Insurance is a radical departure than the way those products used to be filed. There are no more writers. Writers are gone. So when I file a product with the Department of Insurance as a health plan, I either have to say that the dental benefits are in or the dental benefits are out. There is nothing of it's an option anymore. So those are 2 different products that are being filed with the Department of Insurance. One has dental in it, one has dental out of it. And that's to John's point of when he's saying there's five products or a limit of 5 health plans, if we're going to use the appropriate terminology. The 5 plans are the 5 different products, and if dental is in, then that's taking one of the slots then out of those 5. So if what we want to do is have an option of having the dental in and the dental out on the same base medical structure, then that would need to be increased to 10, with the only variance being the dental benefits between the 10 plans. So I don't know if there's a beautiful way, John, for you and your staff to word that in the recommendation. But I think that's what I heard Lynn say. I think that's what I heard Dr. Klein say, which is they're not opposed to having 5 plans, and those would be 5 with dental and 5 without dental, as long as they're the same 5 plans. The challenge for us as carriers is that we don't get that option anymore. We have to file each of those products separately. So in our eyes, those are 10 plans. And that is how it's filed with the Division of Insurance now.
So this is Lynn. Madam Chair, may I ask a question?
yes, please.
So when we're having discussions about embedded and bundled, are those terminology? Is that terminology wrong?
Those are exactly the same thing. So if it's a bundled product, that means the dental is in. It is embedded in the plan. If it is carved out, is actually the opposite. So it's either an embedded product or it's a carved out product. If it's carved out, then that means it's going to be offered by a standalone dental carrier. If it's embedded, then that means that it's being managed and handled by the medical insurance carrier. So it's embedded versus carved out. Does that make sense?
Yes, that does. So, I mean, this is Lynn Atkins. I would be okay as long as it's very, very, very clear that a provider is submitting Plan A, and I don't know how these plans are going to be named or if they're going to be numbered or named or how they are, but Plan A, with dental, and Plan A without dental, Plan B with dental, Plan B without dental. And if it's that clear, and if our motion is, and our rules are very clear that it must be the exact plan, and the only variation can be that it either that it has dental, I am okay with that.
And I agree with Dr. Klein. I agree. And I think we're all saying the same thing, and we're just trying to, we're trying to figure out a legal way to say that even though the Division of Insurance Counsel has two plans, that in our head they're basically the same plan with two different versions. And however we get to that, what we don't want to have happen is for us to say 10 plans and have a carrier offer 10 different QHPs with different medical plans, basically flooding a tier by using that exemption and really just not doing anything with dental. We want to make sure that if we're going to double the number to 10, it's very clear, as Lynn Etkin said, that we're referring to five base medical plans, I think the term you used, with variations based on dental, not for any other reason. So however we say that legally is what we're trying to get to.
John, do you think that we might be able to say something no more 5 QHPs and no more than 5 QHPs with dental? So, you've got a maximum of 10. That doesn't mean they have to bring in 10. They could bring in 6 or 7.
I'm not sure exactly how to phrase it. I get the intent of what Dr. Klein and Ms. Atkins are saying. I just want to make sure that we're clear, and this was to Ms. Gasaway's point about you're providing 10 different plans. When we provide those plans on the exchange, when we provide embedded products side by side with products that don't have dental embedded, it would in fact double the number of qualified health plans that are visible on the exchange.
And I think that's a correct assumption. I think that that's how they have to be filed with the Division of Insurance, because under the SIRF system and the regulatory filing system, the base product that is being filed, of which those plans are, the cost sharing for each of those plans is derived from, when you add or subtract a benefit, and dental would be an additional benefit, that changes the base product. So dental it's not a rider, it's not an add-on, it is in the base product that's either being filed in that product form with the division or not. And that's how they have to be filed in SIRF, and that's how they will be submitted to the exchange in the binder.
And this is Lynn. I'm assuming as part, and I think we'll see that at the June meeting, but maybe not. When people are in the software system and when they're going through the selection, I'm assuming one of the preliminary questions could be, are you also looking for dental coverage? And if the answer is yes, then they'll only show the 5 with dental, and if the answer is no, they'll only show the 5 without dental? Or, I'm just wondering if that's a way to clear it up as far as the consumer starting to search.
That's a potential method. This is John Hager. I don't know if we've started it that way, because I think what we had presumed in the past was you select a qualified health plan, and if it doesn't include dental, then it asks whether or not you want to purchase dental. The other part to that is, based on the board's decision at the last board meeting, we're going to require the purchase of dental for children. And I don't know if it gets confusing then if you say, do you want dental? And then you select, and if you say no, then we require you to take a dental plan anyways. Although we could work that out as well.
John, I know that we don't want to have more meetings than we absolutely have to, but I think we're going in circles, and I think you're clear as to what we're clear as to what we want. We just aren't clear as to how to get there. Do you think maybe tabling this and coming back in a week or with a June board meeting and having you craft some language that accomplishes what we're trying to get to might make sense?
They have to file with Division of Insurance by June 7th.
I think any carrier who's listening clearly understands what we're trying to say, and it's just a matter of saying that in a legal way. So I don't think there's a lack of transparency on our part. We're pretty clear as to where we're trying to get to.
Let's see if Mr. Bill might offer some assistance here. because I think it would be helpful if we could move on this, if we could get some clear language.
But this is Lynn. I'm sorry to interrupt, but I'm also kind of hearing that if the software system can't initially start sorting out whether or not someone wants dental or not, then I think all of this is kind of for naught. I don't know why we're kind of having this discussion. If people are going to be asked later if they want to purchase dental, but it's already in the system, I mean,
So,
how much can be changed with the software system right now?
for the record, John Hager, I mean, every time we add a change, it's another risk to the project. I don't think that piece is significant. The concern isn't the software per se, as just the logic behind it. If you're going to say, and I suppose you could say kids have to purchase dental, and you show all plans, but adults don't have to, and so you give the option for the adults on whether or not they want to choose dental. Or maybe the more appropriate question is, do you want to purchase do you want dental embedded in your product or not? Although I don't think the consumer will understand that. I'm not sure it makes sense to ask the question beforehand. The other concern I have is if we say you've got plans A, B, D, C, and E without dental, and then you have plans A, B, C, D, and E with dental embedded, I'm not sure that those plans are still, I'm not sure if that's still Plan A. It's a variant of Plan A. There could potentially be a change to a deductible or co-insurance or a copay or something because you've embedded dental. So I'm not sure it becomes exactly the same plan. It becomes very difficult to determine how to say that plan is still the same plan. I don't know if Commissioner Kipper has something to add to that.
John, what if is Commissioner Kipper there?
I think he might have had to drop off.
What if we said something like a plan can offer a carrier can offer 5 plans with dental insurance and 5 plans without. So they can offer a maximum of 5 with and offer a maximum of 5 without. Does that get us to that point?
No, this is Lynn. No, because then there's no consistency on those plans, and it'll just end up being 10 different plans. Personally, I think.
I get what you're saying, yeah.
I'm starting to lean more towards leaving everything as it is, listening to all this.
Yeah, but then if it counts as, then we basically have the number of medical plans a carrier can offer. If they offer Plan A, version 1 and version 2, and that counts as 2 rather than 1, then we just have the number of plans they can offer.
For the record, John.
I'm listening to what Ms. Atkins had to say. Given the amount of time that they have left to develop this, which is about a week, I'm not sure that they're going to be creating all new plans. So, I think they've all been focused on 5 plans right now. I don't think that it would be easy for them to create 10 new ones or 5 new ones. So I guess I would be inclined to do what Dr. Klein suggested, 5 with and 5 without dental. And if we see that they're abusing or going awry on it, we can change that next year.
I understand Ms. Atkins' point, but I think you're right also, Chair Campbell, that I think there's not enough time for them to create mischief. So I think just keeping it simple with their loopholes, and then addressing it next year probably works for me, or does work.
And this is Lynn, and I can't remember who all the board members who are on. I'd like to know, do we have to... I'm not sure what... all right, I'm sorry. My mind is focusing elsewhere at the moment. Is there a reason why we're kind of focused on 5 plus 5 anyway? Like, why couldn't it be 1 additional or something? I mean,
Because I think we want for each of the 5 medical plans to have the option of dental or not dental for each of the 5.
But I assume that some of the, and maybe I'm wrong, so maybe I think we've kind of cut off public comment in a way. We only heard from one person, but I'm assuming some of the plans already were going to include dental, or do we think that or no?
For the record, John Hager, I don't know, but I would assume that somebody out there wants to provide a dental plan embedded or bundled. I don't know. Based on some of the discussions that I've had, it appears that some organizations are worried about not offering it at all, that they would like the ability to have it embedded for all their plans so that they don't have any plans offered outside the exchange that don't have it embedded. I don't know what the carriers are going to do.
Do we have any carriers on the line who might speak to this?
And
for public comment?
Ms. Gassaway represents the carriers.
Okay.
But John, in fairness, I don't know what my plans are. They do not disclose that to me, so I do not know, unfortunately, which ones plan and what they plan on filing with you. I apologize for that. Maybe, I hate to, if anyone on the insurance division may have a sense of what's being filed.
Is Commissioner Kipper on the line?
I am. We've had one company file, and I'm not sure the specifics of their filing.
I don't know. My feeling is that we want to encourage people to be a player on the exchange. I think my instincts are, given the time frame right now, I would agree with Dr. Klein. There's not much time to create any mischief. And all of us are second-guessing what anybody's going to do at this point. So I would rather keep it more open than restrictive at this point, and then revisit this issue maybe in January after we see what we've got and we're setting the rules for the next calendar year.
This is Lynn. Again, how can someone tell me how these plans are going to, like, what are these plans going to be named? Do we have any idea? Is it going to be, Anthem, Blue Cross Blue Shield, Gold Plan? I mean, do we know how they're going to be named? Are they going to be numbered, or do we have any idea about that? Because if we can make this very clear that we are only allowing 5 plans as we discussed, but if these exact same plans just have an additional dental benefit, then that won't count against the 5 plans. Or something like that. I just want it to be really, really, really clear that we are not talking 10 plans. I don't want our motion to be 10 plans. I want it to be 5 plans plus dental on each, but that it has to be very clear in the name of the plan, which plan it's corresponding with. So if it's plan Pine Tree, then it's plan Pine Tree plus dental, and plan Oak Tree plus dental.
All the plans are going to be named after trees now.
I mean, is that possible, or am I living in some little simplified fantasy world?
Well, I think we're getting down in the weeds a little bit too much, because I think that's going to be up to the carriers how they do it. They're going to be allowed right now 5 plans per service area, and we're looking at expanding that up to a maximum of 5 qualified health plans plus 5 qualified health plans that include dental per service area, per metal tier.
As long as those are the same 5, I think to me that's the key. As long as those are the same 5 metal plans that they submitted without dental.
Madam Chair, I think Ms. Lewis had a comment.
Yes, thank you.
Now, I was just agreeing with your suggestion, Madam Chairman, that we, go with what we have and look at it in January to see if we have people who are then operating outside of what we felt were the purviews of this particular decision. And that was the comment that I had. But I understand what Ms. Atkins is saying. She does not want people getting 5 plans with dental that are different from the 5 plans without dental.
Ms. Kerr, do you have any comments?
No comment. I'm sorry. And legislative drafting on short notice is not really my forte, or drafting this stuff on short notice isn't my forte. I tend to go with the chairwoman's recommendation. I think that's the best way to go.
Mr. Belcourt, do you have any magic words that you could offer to us?
Dennis Belcourt. I think you made it very clear what you want, and that's basically 5 qualified health plans with a dental, with an option, a dental option on each one. Now, is that legal? 5 qualified health plans with an option of dental on each, and that, I think you're making the dental the optional to the health plan. So, does that sound like it's? I guess I would, on the fly, that's how I would phrase it. May have up to 5 qualified health plans with a dental option on each.
Okay, per service area, per metal tier.
Madam Chair, this is John Hager. Can I ask Commissioner Kipper if that's even possible, if you can have qualified health plan Oak Tree with a dental plan and qualified plan Oak Tree without a dental plan, and if it would still be Oak Tree?
Not sure I understood the question completely, John. You take a run at that again.
So if you have a qualified health plan, a medical qualified health plan that has embedded dental, and you submit another medical qualified health plan that doesn't have dental, could you in fact design the medical portion of that qualified health plan to be exactly the same, or will you run into problems keeping it the same because of the lack of dental and how that might affect the actuarial value and things like that? Would you have to change the medical portion of the benefits if you altered whether it has dental or not?
Well, that's probably a technical question beyond my instant answer.
Okay.
We'll have to ask my staff of experts over here. My sense is that we're talking about 2 different things.
Okay.
But I would have to let me check with my guys.
Can I maybe rephrase again? We all know what we're saying, but we're not being able to word it. Can we? Do you think this might be worth coming back in a week after people have had a chance to craft some language, or? I'm just afraid that we're going to make a decision because we don't know what else to say or how to say it that we might regret. So. Well, again, I get back to the point it's been made several times earlier in that, if companies have made the decision to create a plan, they are well down the road to getting those plans into our office for review, so that if decision made has already been made as far as the number of plans the company's going to file, and that a change today may not be will not be addressed. If I could offer some advice, perhaps it would be to say, let's take some time and study this for submissions for plan year 2015, so that we can give good and clear direction for plans for the next filing session. So, Commissioner, if we don't change it, my concern is that if we don't change anything and leave everything the way it is, that we basically cut the number of options in half for people on the exchange, because where there's 5 plans, now there's 2 or 3 with plus dental and minus dental versions. So my concern is just that we're going to actually decrease choice by doing that.
Well, and I can appreciate that, and not to be argumentative, but I think those decisions have already been made.
Okay.
And I don't know that any decision we've made, even if it was made within the last month, would make a difference in the number of plans that companies would have filed.
Commissioner, and I know you're asking a question you can't answer. Those are my favorite kinds of questions. Do you have any sense if the carriers are coming up against this 5 limit and raring to have 7 or 8, or do you get the sense that they have 2 or 3, and if we add dental or not, it's not going to matter either way?
I don't have a sense for that, Dr. Klein. That's a very good question. I can tell you that I personally have not had any conversation with carriers asking for a theoretical expansion of the number of plans that might be offered, and I don't believe anybody's asked my staff that question.
So perhaps, as you said, Commissioner, just leaving things alone for now and seeing what happens.
At least that's certainly an option, and it's an option in a known set of variables that we've been dealing with.
This is John Hager. The only conversation that I've had outside of the committee meeting on May 15th that was about a month ago that I think, I know it was one, but I can't remember if both MCO plans requested that their transition plan not be included in the 5. And I forgot to bring that forward earlier.
I think my impression, having worked on this advisory committee and having a couple of carriers on that committee, is that they were very interested in being able to expand the number if they had dental, but it wouldn't be counted against them. And I don't know how representative they are of all the carriers.
So the other option we could do, which would again not address Ms. Etkin's concern, is change the number from 5 to 10, and along the lines of what Commissioner Kipper and Mr. Hager said, assume that nobody's going to be able to rapidly add 5 more medical plans, but all they'll really be able to do is to add or subtract dental, and so just give them 10 on the assumption that there's not enough time to flood the system.
Well, and I would offer a little bit more clarification to that, Dr. Klein. If we expand it out to 10, then I would put the caveat in there that 5 of them must include dental.
Okay, I agree. And then, do you want to further say 5 of them must not, or just say 5 must include dental, so they're going to include dental?
Right. I would say 5, of which 5 must include dental. So it leaves the option up to them.
So
This is Lynn. I would prefer to, if we have to do this, again, it just sounds like now we're just expanding it, we're just doubling the number. I think Mr. Belcourt's suggestion that it's 5 plans, and then you can also have dental on those plans is what we're talking about. We're not talking about 10 plans.
But they count, unfortunately, because of the way they count things. A plan with dental and without dental for division of insurance purposes counts as 2 plans. So even though I know what you're saying and I agree with what you're saying, Plan Oak and Plan Eucalyptus, if I can spell eucalyptus, they still count as 2 plans. So that's the problem.
Madam Chair, this is John Hager. We started with some public comment, but we only had one person get in their comments before we started asking questions. It might be appropriate to continue that public comment if anybody else has some. Just to make sure that it's fair.
Probably burned them out. I would like to try and offer some resolution so people know today what the board's decision is. We're just so short on time. And I would hate this discussion where we've set intent come about and be something different a week from today. That's just not fair to the carriers. John, do you want to take a crack at a motion? Or Lynn, do you want to take a crack at a motion where you're comfortable?
This is Lynn. I'll take a crack at a motion. I don't know. I'm assuming Mr. Belcourt's suggestion is something that will work. So I am going to move that we that we keep the 5 plans per tier level, per carrier, per service area. And if those plans have a dental option as well, they won't be counted against the 5.
Okay, is there someone that is willing to second that motion?
Marie Kerr, I second it.
Okay. I'll open it up for discussion on this. I think I would like to put on the record that we do recognize that the Division of Insurance may interpret these as two separate plans, whereas the exchange is viewing them as one plan, just so that we have a little bit of clarification on that. Anybody else have any other comments or suggestions?
For the record, this is John Hager. So that I'm just so that we're clear, if a carrier offers 5 qualified health plans and each with dental and without, so 10 total plans, that all 10 of those plans would be displayed on the web portal when they're selecting their qualified health plans.
Well,
Don, I'm not sure we want to get into how it's being displayed. That's a mechanical thing for you and the consultants to try and work out at this point.
Okay.
I think just come to a decision or a not decision. Any other comments on this?
Nope.
John, let's have a roll call vote on this, please.
This is Dr. Klein. Can you repeat the motion before we vote?
Okay. Ms. Atkins, do you want to repeat it again, please?
sure. The number of plans per carrier, per service area, per tier will remain at 5, but the carriers can add a dental benefit to each of those 5, and it won't count against the 5. I know that's not completely artful, but that'll have to do for today.
We get the intent, the exchange, and we can craft the wording correctly, or it's close enough.
All right, does that clarify it for you, Dr. Klein?
If they have a dental plan in the QHP, it doesn't count against them. But if they don't have it, so if they don't have a dental option, it counts as a 1 against the 5. But if they do, it doesn't count. Okay, understand that correctly?
Say that
No.
again, Dr.
That's not.
Yeah, now you're confusing me.
I think you said it backwards.
Okay.
Make it,
The same 5 plans can have a dental option, and it won't count against that plan. The idea is that you can't create a whole. You're not getting 10 plans. You're getting 5 plans, and then 5 of the same plans plus dental.
We agree, and we just couldn't get to the wording of it. So yes, okay, thank you.
All right, Mr. Hager, do you want to take a roll call vote, please?
Yes. Ms. Lewis,
aye.
Dr. Klein,
Aye.
Ms. Kerr,
Aye.
Vice Chair Atkins,
Aye.
and Chair Campbell.
Aye.
And that passes unanimously. The other hanging item was the exception for the transition plan.
And I didn't hear an answer from Mr. Belcourt whether or not we had that properly noticed.
Okay, thank you. I looked at the transition plan is to be, or the MCO plan, our transition plan, is an additional plan over and above the 5. And the concern is it wasn't in the packet that you guys had as a part of the proposal, but the agenda doesn't. Where the other, is that what I'm understanding?
Yeah, I just want to make sure we're okay moving forward on it.
Well, I think if to add the MCO transition plan in there would be to increase it to 6 or whatever, that's within the scope of the agenda item.
Okay.
You're okay.
Good. Well, that's all I wanted to hear, is make
Okay.
sure that we're okay with it. So,
All right. Yes.
do we want to have picking up the second issue that Mr. Hager has brought forward on the MCO? I think we've discussed it enough that people understand what it is. It's the transition plan that takes care of the churn issue that we've talked about for the last year and a half. does anyone want to make a motion to say if a carrier brings a transition plan on, it doesn't count against them for the 5 qualified health plans?
Dr. Klein, I think the specific thing was they can add one per. They each can add one, not unlimited. Is that not correct?
That's correct. One per service area. So you're talking 2 service areas, Clark County and Washoe. They would each get 1 additional MCO, and it can only be an MCO transition QHP. It cannot. It has to be that particular plan in each of those service areas. So,
And
yeah.
We don't want to restrict it to 2 service areas. We want to say 4 service areas, don't we?
The MCOs are only available in 2 service areas. So how I would craft it is that 1 silver Medicaid transition QHP per service area is required to be offered in the individual market pursuant to the MCO contract with Medicaid will not count against the 5 QHPs in that service area.
Can I move what you said, John?
That would work.
All right, I move what Mr. Hager said.
Is there a second?
Second motion, Levon Lewis.
Thank you, Ms. Lewis. Any further discussion? And John, I'll ask for a roll call vote on this as well.
Ms. Lewis?
Aye.
Dr. Klein?
Aye.
Ms. Kerr?
Aye.
Vice Chair Edkins?
Aye.
Chair Campbell?
Aye.
Motion passes.
Okay, I believe that can end item number 4. Is there anything else, Mr. Hager, that we haven't covered in that item?
Nope, that's it. Thank you very much.
All right. Do we have any other possible action items for our next meeting?
We will add the discussion about the Medicaid transition plan to the next discussion.
Okay. And I'll open it up again for public comment. Could you please identify yourself if you would like to testify at this point in time?
Nobody here in Carson City.
I'm not hearing anything on the phone line either. So with that, I'm going to call for the adjournment, and I want to thank everyone for their participation and you and your staff for the help.
Thank you.